Hello. We're now going to lecture over airway management, chapter 10. This is a 4-part session. This will be part 1 of 4. And just to let you know, there are a few fill in the blank type slides. So I would definitely have some form of writing utensil and paper next to you so you can make your notes where when we're at a spot where it's a fill in the blank. There's not a lot of them, but there are a few. And there'll be numerous lectures throughout this program that have fill in the blanks. So airway management is the most important skill that you're going to need to master as an EMT, because nothing else matters if the patient does not have an airway. If the patient stops breathing, it's not long until the heart stops beating. But if the patient's heart stops beating first, the breathing will stop almost immediately. So the 3 main responsibilities we have for our patients is maintaining an airway, maintaining their breathing, and maintaining their circulation. So when the ability to breathe is interrupted, oxygen delivery to the tissues and cells is compromised. Vital organs may not function normally, and brain tissue will begin to die within 4 to 6 minutes. Our job as firefighter EMTs is to be on the scene in less than 5 minutes. That's from the time the call comes in to the time we're on the scene. The quicker we get there, hopefully we can be there within that 4-minute time frame and begin maintaining their airway, their breathing, and their circulation to hopefully decrease or not allow any brain damage to occur. So our job is to immediately assess and correct life-threatening problems with the big 3 of airway, breathing, and circulation. The anatomy of the respiratory system. The respiratory system consists of all the structures that make up the airway and help us breathe and ventilate. The airway is divided into the upper airway and the lower airway. And it's good to know which structures are in which part of the airway. The respiratory system consists of the upper airway and the lower airway. The upper airway consists of the nose, the mouth, the pharynx, the oropharynx, and the nasopharynx, the epiglottis, the larynx, and the cricoid cartilage. With that said, the oropharynx and the nasopharynx, where they come together in the back of the throat, is known as the pharynx. The epiglottis is a leaf-like structure, that flap that goes over the trachea when we either swallow or are eating food, to keep fluid from going down into the lungs. The lower airway consists of the trachea, the carina, the bronchi, the bronchioles, and the alveoli. The upper airway, the main function of the upper airway is to warm, filter, and humidify air as it enters into the body. The term respiration is the exchange of gases between the lungs and the environment. The respiratory system function is to breathe oxygen in and breathe carbon dioxide out. The alveoli is where the oxygen is exchanged with carbon dioxide. No gas exchanges in the dead space of the bronchioles, the bronchi, or the trachea. Those are just pathways for the oxygen to get down into the lungs to the alveoli. Our upper airway, known as a pharynx, is the muscular tube extending from the nose and mouth level to the level of the esophagus and trachea. It's composed from the top to the bottom of the nasopharynx, formed by the union of the facial bones, where it warms and humidifies air as it enters the body, and the oropharynx, which is the posterior position or portion of the oral cavity. It's also an entrance for respiratory and the digestive system. It's where the esophagus comes in and the trachea. And it lies superior to the larynx, and larynx is the epiglottis. Remember, the epiglottis is a leaf-like structure that goes over the trachea. Anytime we swallow or eat, it covers the trachea. And then we have the laryngopharynx, also known as the hypopharynx. The upper airway on the larynx, it's a complex structure, and it defines upper airway and lower airway. The thyroid cartilage forms a V shape anteriorly, and you can feel that as you run your fingers down each side of your trachea. You can feel that little V shape. And then we have our cricoid cartilage, which forms the lowest part of the larynx. The epiglottis, remember, is the leaf-shaped flap that covers the glottic opening. It's to keep food and fluid out of our lungs. Here we have the anatomy of the lower airway. And the function of the lower airway is to exchange oxygen and carbon dioxide. It includes the trachea, the bronchi, the bronchioles, and the alveoli. The trachea is the conduit for air entry into the lungs. It divides at the carina into two main stem bronchi, the right and the left. The bronchi are supported by cartilage. Remember, the trachea itself is mostly cartilage. So the cartilage then extends down into the right and left lungs. The bronchi are supported by cartilage, and the bronchi distribute oxygen to the lungs. The bronchioles are made up of smooth muscle, and they dilate and constrict as oxygen passes through them. And then at the far end, we have the smaller bronchioles connected to the alveoli. Now the carina, think of it as like a Y intersection. That's the medical name of that Y section at the end of the trachea, going to the right and left lungs, is known as the carina. So the alveoli are the site for gas exchange, and the oxygen is transported to the alveoli and exchanged with the CO2 in the blood, of which the CO2 is then exhaled. So with the alveoli are little sacs of grapes. It's kind of a easy way to explain them, except they're very they have a lot of elasticity in them, and every time we breathe in, they get big. Breathe out, they get smaller. Breathe in, breathe out, bigger, smaller. And this will play into more when we talk about some COPD type stuff. But the alveoli can eventually wear out because of the massive use of them. We're going to talk about the physiology of the respiratory system. Here we have some fill in the blanks. We have three aspects of respiratory physiology. We have ventilation. Ventilation is the physical act of moving air into and out of the lungs. Breathing in and out, breathing in and out. Oxygenation is the process of loading oxygen molecules onto hemoglobin molecules in the red blood cells. So we're loading up oxygen molecules onto the hemoglobin of the red blood cells to ship that off to be exchanged at the alveoli. And then the term respiration is the actual exchange of oxygen with carbon dioxide in the alveoli at the capillary beds of the tissue and at the capillary beds of the tissues. Remember, the capillary beds, we can check at the fingernails, we can check on the back of the hand. All we're doing is just pushing down, blanching out those capillaries, and they should refill within 2 seconds, which means we have adequate circulation. Term inhalation, inspiration. This is the first step in ventilation. Inhalation, also known as exhalation, is an active process. We have to work to inhale. So what happens? The diaphragm and intercostal muscles constrict, ribs move upwards and outwards. The diaphragm, which is the major muscle used for breathing that separates the chest cavity from the abdominal cavity, moves downward, and the chest cavity increases in size. The intercostal muscles move the ribs up and outward, and the diaphragm moves downward, and the intercostal muscles are between each rib that help us with our respiratory rate. So what this does is it expands the cavity, the chest cavity, and allows for air to be drawn in and flow in because of the pressure changes. Exhalation or expiration is a passive process. We can't hold our breath forever. So give it a try. See how long you can hold your breath. Because we're eventually going to have to get a breath of air because we need to breathe out the buildup of a certain type of gas. CO2. So with our exhalation, the intercostal muscles relax, the ribs lower. When the diaphragm relaxes, it moves upward to its normal resting position, and the size of our chest cavity decreases, and air flows flows out and is compressed out by the decreasing cavity size. Exhalation. Talk about some patho of respirations. The factors that affect pulmonary ventilation remember the term ventilation, we need to maintain a patent airway. That is critical. But we have some factors that can affect whether we're getting good pulmonary ventilation. We have both intrinsic factors and extrinsic factors. Intrinsic factors are factors that are originating from or situated within an organ or tissue, such as infections, allergic reactions, unresponsiveness due to tongue obstruction. These are intrinsic factors. These are something happening situated within an organ or tissue. Now, one of the things we can do for intrinsic factor, there's not much we can do for an infection, but we can with allergic reactions, in that we can give them EpiPen shot, we can give them oxygen. The unresponsiveness, the intrinsic factor of the tongue obstruction, we can readjust the head to get the tongue off the back of the throat, or we could very well insert a oral pharyngeal or a nasal pharyngeal to move the tongue off the back of the throat. Extrinsic factors such as trauma or foreign body airway obstruction, extrinsic factors pertain to anything external or originating outside a structure or organism. Extrinsic. Such as trauma, there may be blood, teeth in the airway. We need to get that out so we can fix that factor. Foreign body airway obstruction, we can fix that by doing the Heimlich maneuver, getting that foreign body airway obstruction out of the throat. We're going to talk a little bit about the assessment of the respiratory system. We have some goals that we need to accomplish with respiratory assessment. We need to determine if the patient is breathing. We need to determine the patient's condition. We need to know if they're adequately breathing or are they breathing inadequately. The way we can figure out if they're breathing adequately or inadequately is by looking, listening, and feeling. And that means getting your head down near the patient's airway, the mouth, the nose, and we do a look, listen, and feel. We're looking for any chest rise and fall. We're listening if we can hear anything with the breath. Noisy breathing is bad, but we'd like to hear something. Or and feel if we can feel them breathing out adequate amounts of air. Respiratory failure, we need to be able to recognize inadequate breathing, and this requires both excellent assessment skills and prompt action. Because respiratory failure is the reduction of breathing to the point where oxygen intake is not sufficient to support life. And respiratory arrest is when breathing stops completely. So we need to find out if they're breathing adequately or inadequately. We look, listen, and feel. We need to be able to determine if they are going into respiratory failure and try to fix that problem at that point. What we don't want to do is wait till the patient, we're going, I think they're breathing adequately, but they may be breathing a little inadequately. But if I wait long enough, I'll be able to tell because they'll start going into respiratory failure. But there's a fine line between respiratory failure and respiratory arrest. Don't wait for respiratory failure to become respiratory arrest before you do something about it. So signs are something that we can see. Signs of adequate breathing, we're going to look. We're going to look for equal rise and fall of the chest, meaning do both sides of the chest go up and down equally? We're going to look at the skin. Is it pink? Is it pale? Is it blue? A blue hue to the skin is known as cyanosis. cyanosis, cyanosis. We're going to listen. Does air move in and out of the mouth and nose? Their breath sounds equal and bilateral. We're going to use our stethoscope. Do we hear breaths on both sides of the chest? Are they bilateral? Are they equal? Are there any sounds that shouldn't be there, such as snoring respirations, gurgling respirations? Gurgling, snoring is the tongue blocking the airway. Gurgling, there's fluid in the airway. Could it be crowing? Some phlegm, stridor. Stridor is the only upper airway obstruction that it's right at the base of where the collarbones come together, right at the top of the sternum. That's where you'll hear it best with the bell of your stethoscope. Wheezing, lower airway obstruction. We normally see wheezing with asthma type attacks. But any audible sounds of breathing are considered inadequate breathing. And feel. Can you feel air moving in and out of the mouth or nose? Then you want to check, when we're checking for adequate breathing, the rate. The adult rate is 12 to 20 times a minute, but remember, the National Registry might use 8 to 24, where 12 to 20 comes into play there. So think from 8 to 24. A patient can be breathing 24 times a minute and be breathing adequately. But American Heart Association reads 12 to 20. So 8 to 24 would allow 12 to 20 to be inside of it. Children, 15 to 30 breaths a minute. Infants, 25 to 50. Never greater than 60. So if they're at 52, you got to start thinking that they might be going into respiratory distress. Respiratory distress that's untreated leads to respiratory arrest. Respiratory distress, respiratory failure, those two words are intertwined, failure and distress. The rhythm, is it a regular rhythm? For adequate breathing, it should be regular. The quality meaning breath sounds, are they present and equal? And is minimal effort for breathing? The depth meaning, does the chest expand adequately and equally? So if we have adequate breathing on one hand, we've got inadequate breathing on the other hand. So with inadequate breathing, we look at the rate. Are they breathing too fast or too slow? Do they have prolonged inspiration, which is a sign of upper airway obstruction? They're taking a long time to get air in. That's upper airway obstruction. If they have prolonged expiration, taking a long time to get the air out, that is a lower airway obstruction. Is their rhythm of breathing regular or irregular? The quality. Do they have any noises that you hear? Abnormal breath sounds or diminished breath sounds that they're hard to hear? Do you hear snoring, gurgling, wheezing, stridor, rhonchi? Do you hear any noisy breathing? If so, it's inadequate breathing. Are they having an increased effort to breathe? And then our depth. Are they breathing shallow? Or are they breathing deep? Or are they breathing labored? They're struggling to breathe. Think of labored after you've run a marathon. If you're a marathon runner, you have a form of labored breathing, but it's not the inadequate type labored breathing. And also with depth, any abdominal breathing, which is normal for peds, abnormal for adults. Is the patient unable to speak or cannot speak in full sentences? This is known as 1 to 2 word dyspnea. What we mean by 1 to 2 word dyspnea is I'm having trouble breathing today. Hey, that's a 1 to 2 word sentence. They're not able to say, I'm having trouble breathing today without taking a breath every word or every 2 words. 1 to 2 word dyspnea, unable to speak or cannot speak in full sentences. Their skin may appear pale or cyanotic. If they're cyanotic, cyanosis is a late sign of hypoxia, meaning difficulty breathing. They're not getting adequate oxygen exchange, hypoxia. Is their skin cool and clammy? Cool to the touch, clammy, kind of that sticky feeling in between spring and summer type deal, where you get out and it's just kind of, you just feel, ugh. So that's our adult adequate and inadequate breathing. But we also have another area of the population, infant and children. Inadequate breathing in infant and children, they have unique characteristics with inadequate breathing. They have nasal flaring. They're breathing so hard, they're trying to breathe whatever way they can, and you will see their their little nasal area will flare out because they're trying to breathe in. They're having so much trouble breathing. They also have seesaw breathing, also known as belly breathing. Gives the appearance, the belly gets big, then goes down, the chest looks like it gets big, then it goes down, the belly gets big. Seesaw breathing. Retractions. They might have intercostal retractions around the rib cage. As you can see in this picture, where you can see this little guy's ribs, that's the intercostal muscles being used in between the ribs. The diaphragm on the pediatric and infant and children is not fully developed. They have a little diaphragm. So if they're working that hard to breathe and having to use their accessory muscles, which are not fully developed yet, these kids are already in respiratory failure. Without helping them, their respiratory failure is going to go to respiratory arrest quickly. Kiddos compensate real good for a while, but they decompensate faster than the adult does. We might see suprasternal retractions at the xiphoid process. We might see subclavicular retractions, which is on top of the breastbone, where they're using muscles to breathe, and you can literally see the breastbone, the top of the breastbone where the clavicles come together. Intercostal retractions include the ribs. Substernal retractions, you would be able to see the xiphoid process, which is the lower part of the breastplate, the breastbone. It's the little, looks like a little dagger. And then the supraclavicular retractions. You'd be able to see the top of the breastbone where the collarbones come together. We're going to talk about management and opening of the airway. First and foremost, opening the airway. The goal is to establish and maintain a patent, clear, and open airway. Most airway problems are caused by patients who are found in a position other than supine. If you find them prone, they should be in a supine position on the floor or stretcher for evaluation and treatment. And to do this, you log roll the patient into the supine position. If there's any trauma suspected, the cervical spine should be protected. Manually stabilizing the spine is the first step, especially in the patient that is unconscious. If the patient's unconscious and people can tell you how they got into the position that they are in, C-spine isn't as major concern. If they say they were standing there and all of a sudden they fell down onto the ground, yes, there you need to maintain manual stabilization. But if somebody tells you, oh no, I helped them down to the ground, laid them down, and then they went unconscious, you don't have to worry about the manual stabilization as much. So indicators of some possible C-spine injuries can include the mechanism of injury, what event occurred that may have caused the injury, which is known as a mechanism of injury. Think about any injuries above the shoulders, and I actually use about the nipple line and up, as if you have any major injuries from about the nipple line up, think about manual stabilization. Witnesses tell you how the injury occurred. It was a car wreck, they got shot. Our goal is to maintain a patent airway that is open and clear without interference to the passage of air in and out of the body. And most airway problems are caused by, that's right, you got it right, the tongue. The tongue falling back on the throat. If our patient is suspected of having any head, neck, or spine injury, or if unknown and your patient is unconscious, if it's unknown how they became unconscious or how they got to the position they're in, you should have your partner hold C-spine when rolling your patient supine. Then we're going to use a jaw thrust maneuver to open our airway. We don't use the head tilt chin lift method on any trauma or unknown or suspected trauma. The head tilt chin lift method, there's no C-spine injury is suspected, Open the airway, then manage the airway using the head tilt chin lift method. This provides for the maximum opening of the airway. It's also a great method for correcting the most common airway obstruction, the tongue. To do this, we're going to put one hand on the forehead and fingertips under the bony area of the chin. Tilt the head back. Use your fingertips to support the lower jaw, but don't compress the soft tissue because this can actually obstruct the airway. And don't stick your fingers or thumbs in the mouth. They might get bit off by the patient. You never know. Our jaw thrust maneuver. If you suspect C-spine injury, then utilize the jaw thrust maneuver. Keep the head and neck in alignment. Kneel or lay down on your belly at the patient's head if needed for any length of time. You can rest your elbows on the floor. You're going to place hands on both sides of the jaw at the angle of the jaw below the ears. Stabilize the head. Use your index fingers, your pointing fingers, those are the index fingers, to push the angle of the jaw forward. Don't tilt or rotate the patient's head. The idea is to keep it aligned with the neck. And be prepared to suction the airway anytime the patient is incapable of protecting their own airway. This is the end of part 1 of 4 parts of chapter 10.